Hi, my name is Dan Joyce. I'm a urologic oncologist at Vanderbilt University, and I have the pleasure of visiting here with Dr. Wenxin from Dana-Farber Cancer Institute, who just gave an excellent talk on a very exciting topic on a new biomarker for renal cell carcinoma, KIM-1. We've talked about this before, but we have now new data looking at CheckMate 214. So let's start, just remind us what is KIM-1 and why are we looking at it?
Absolutely, Dan, and thanks for showing your interest in this. KIM-1 is a circulating biomarker in kidney cancer. So it's a protein that comes from the cancer cell, is circulating in the blood, and you can pick it up on a blood test. What's really exciting about this is that we don't currently have blood tests for kidney cancer, and the hope is that KIM-1 can be a test that can tell us whether cancer is getting worse or better, or if someone potentially even has cancer.
And so last time I talked with you, I know we talked a lot about using KIM-1 in the adjuvant space to decide who might benefit from adjuvant pembrolizumab. The data you presented today a little bit different. So we're looking at CheckMate 214, which looked at ipi/nivo in metastatic RCC versus sunitinib. Tell us what you found with KIM-1 in those patients.
Absolutely. What we know from before from CheckMate 214 is that combination immunotherapy works really great for some patients in kidney cancer, but in other patients it doesn't work so well. And so what we looked for was whether there's a blood test that can tell us how well someone's going to do before we have to get years of follow-up on their treatment. We measured KIM-1 at pre-treatment baseline on 821 patients from CheckMate 214. And we also measured KIM-1 3 weeks, so after one dose of treatment. What we found was that the baseline KIM-1 level was prognostic. People with higher KIM-1 when they're starting out had worse disease and had worse outcomes. But the 3-week KIM-1 was a really good indicator of how well you're going to do long-term. People who dropped their KIM-1 at 3 weeks after immunotherapy had great responses and many years of progression-free survival, whereas patients who increased their KIM-1 after 3 weeks were really going to not respond so well to the immunotherapy.
Can you talk a little bit about the differences you saw in ipi/nivo patients versus those that got sunitinib? Why was KIM-1 not as much of a change in the sunitinib group versus ipi/nivo?
Yeah, that was really interesting. And what you mentioned, Dan, what we saw was that even though the baseline KIM-1 was prognostic in all the patients, the change in KIM-1 was really closely associated with long-term outcomes in just the immunotherapy arm, but was not associated with long-term outcomes at 3 weeks in the sunitinib arm. The other part of this is that we have a poster from Javelin Renal 101, which is another phase 3 RCC trial, showing that actually the 12-week KIM-1 on sunitinib and also on axitinib and avelumab did correlate well with long-term outcomes. So what we're seeing here is that there's some difference in the dynamics of KIM-1 change depending on whether you get an immunotherapy or targeted therapy. And even though it is prognostic and predictive, it takes a little bit longer in patients who are getting that targeted therapy for the KIM-1 levels to reach a steady state.
So you talked about the KIM-1 levels before treatment, high versus low being prognostic. Is there a way to guide treatment decision-making based on those initial KIM-1 values?
That's really interesting, Dan. And I think the short answer is we need more trials to help us make these decisions, because what we know and what we can learn from these existing trials is that KIM-1 is prognostic, or that it is associated with better or worse response. What we don't know is whether changing our treatment decision based on KIM-1 is going to help the patient live longer. And that's something that can only be answered by prospective trial.
Sure. You also said that those KIM-1 levels up front were lower if the kidney had been removed. So if the primary tumor was in place, KIM-1 levels were higher. How does having the primary in place, not having it in place, adjust your interpretation of KIM-1 in the metastatic disease space?
That's a great question too. And what we know is that when we measured all the tumors in the patient, all their target lesions, people who had just a greater sum of total measurements also had a greater KIM-1. And so KIM-1 really is being shed from the tumors, and it's a marker for overall tumor burden. Someone who starts out with a large tumor burden is unlikely to have a complete response to immunotherapy, and we know this from prior studies, especially for people with really large primary 13, 14, 15 centimeter kidney tumors. That tumor is unlikely to disappear completely. We also know from prior studies that if you do a nephrectomy, the KIM-1 goes down very soon after the nephrectomy because you've eliminated that big tumor mass. And so, combining the serum KIM-1 with these radiographic measurements is going to give you a better picture of the overall sort of patient situation.
So I'm a surgeon, so obviously my interest is in the surgery side of this. Are you looking at using KIM-1 in the metastatic setting and having it be a gauge for when, if and when to do a cytoreduction surgically somewhere down the line. Right now, we look at the Kaplan-Meier curves, we look at maybe 8 to 12 months on systemic therapy with durable response, and then maybe we think those patients are the ones we can pull the trigger on. But does KIM-1 have an opportunity there to guide our management?
I think it could. I think it's a great idea. And for example, you could envision you start someone out, they have a really high KIM-1, lots of metastases, but they have a good response to immunotherapy, and the KIM-1 is going down, and it hits, let's say, for example, 200, and it plateaus. It is really tempting to ask the question there, would removing the kidney bring the KIM-1 down the rest of the way, get them to near undetectable, and that person may have a complete response? It's such an important question. It's one of the many questions that I think we need trials to help us answer.
Absolutely, absolutely. So, KIM-1, very exciting. We've never had a biomarker in aRCC that showed this kind of promise. And I think a lot of us are thinking, well, what are the barriers to getting it into our clinics and using it? Is this something that is going to be easily reproduced for everyone to get access to? And what does that look like in the future?
I really hope so. The good news is that technically KIM-1 is not hard to measure. It's a circulating protein. There's a number of methods that can measure it, including we use the electrochemiluminescence assay, but there are certainly other assays. What's going to be important is making sure we standardize KIM-1 measurement, because a lot of labs can do it, but you want to make sure the labs are using the same assay, otherwise the results are going to be uninterpretable. And so the next step is going to be bringing this into prospective trials so that we can have many centers enrolling patients, sending their plasma samples, getting really uniform measurement levels of KIM-1 that can then be standardized into routinely available assays.
Excellent. Very exciting. So summarize for us this CheckMate 214 analysis. What is the clinical take-home of your findings? How can we use the KIM-1 data to actually make differences in our clinical decision-making in this setting?
My take-home message would be that a blood test for serum levels of KIM-1 in metastatic kidney cancer, number one, tells you if you're high, low risk, or intermediate risk to a level that's really a little bit more accurate than even the IMDC clinical risk score. And number two, early changes in KIM-1 at 3 weeks after immunotherapy are quite a sensitive marker for how well someone's going to do over the next months to years. And I envision that in the future, this might be a helpful way to guide us, that we're not keeping people on immunotherapy if it's not working, but giving people an earlier chance to not get more immune toxicity, but to switch to something that actually works.
It's really, really exciting work. Congratulations, and thanks again for taking the time to talk with me.
Thanks, Dan, for talking to me.